Okay, you guys ready to get started? No. We're getting to the fun stuff now.
I didn't say that. That was her, by the way.
All right. So, you guys had your first physio exam. Straightforward, right? Yeah. Very a lot of recall, know the definitions. Blood is another kind of recall one, just know what's going on. When we get to the cardiovascular, then we're going to start getting into a lot of the heavier stuff. You may have seen your grade change a little bit. There are a few givebacks. I will make an announcement later tonight letting you know which ones were given back for what reason. So there are a few. So today, talk about our composition of blood, talk about hematopoiesis, how do we make these cells, talk about a little about red blood cells since we already talked about white blood cells last week. So we don't need to do anything with the immunology. We already discussed it. Now let's talk about the blood components, and then we'll talk about blood clotting a little bit as well. Very quick little lecture. We'll take a break, and then we'll get started with the cardio stuff. And these are our objectives for today. Composition of blood. So we talked about the very, very first lecture talking about homeostasis, and a lot of them are those negative feedbacks. A lot of all these processes are there because of the blood composition. It's keeping the blood composition in a stable environment. And you look at every single solute that's in there, and they all have their normal ranges where they want to be. So all this negative feedback is to defend normal blood composition, keeping our potassium normal. You guys should know now why potassium is so important in the external environment. Glucose. Okay, uncontrolled diabetes has too much glucose in the blood. We'll talk about that in a little bit. But glucose is sugar. Sugar is sticky. So the more sugar you have in your blood, the more sticky your blood gets. We'll talk about that. Again, these are all things that are in the blood that we're trying to control. The cell elements in the blood are red blood cell, white blood cell, and platelets, and they're suspended in the plasma. And the red blood cells are also known as erythrocytes. What does erythro mean? Red. The cyte is the red blood cell. The main job of red blood cells is transport of O2 and CO2. We'll deal with this a lot more next week when we start pulmonary. Platelets. These are your thrombocytes. Whenever you see the word thrombo or thrombus, it means it's a clot. So your platelets are involved with your clotting, so you can stop bleeding. And the last one, white blood cells, are the leukocytes. Leuko means white. Cyte is the red, or the cell. White blood cells, and these are defenses. We've already discussed all that in last unit. So hematopoiesis occurs in the bone marrow. We did talk about this last week, that all those hematopoietic stem cells, they all start in the bone marrow, and then they can differentiate from there. So this is where we're starting from. In neonates, most of the skeleton is metabolically active. All of their bones have the bone marrow that's going to be making more and more of these stem cells. As we get older, in adults, it's mainly in the vertebrae, the ribs, skull, pelvis, and proximal femur. So if you ever heard of anyone getting a bone marrow biopsy, what they're doing is they're taking a needle and they're putting it into the bone marrow and they're pulling out the cells that are in there. And they want to make sure that those cells are still active or still making more cells. And they put them through different tests to see, make sure they go through different germ lines. So that's where, if you have a bone marrow biopsy, that's what they're doing. And that's why they usually go in the proximal hip, because we know that in adults, that area is still metabolically active. From there, we should be able to get active cells. So here's a quick little graph we're going to do. I want you to first look at the top. We have our hematopoietic stem cell. This is the differentiation. It can go either way, red blood cell, white blood cell, from here. It can go to one side, called the common myeloid progenitors, and these will differentiate into things we'll talk about in a second. Or it can go to the common lymphoid progenitor. Leukemias. Okay, there are two different types of major leukemias. I don't know what the two are. There's CLL. The LL is lymphoid leukemia. The other one is CML, chronic myeloid leukemia. If they have ALL, or the lymphoid leukemia, it's going to affect those cell lines, and we're going to learn which ones those are. If they have the myeloid leukemia, it's going to affect the other cells that we're going to talk about downstream, and you'll see which ones are being affected. So let's talk about the common myeloid progenitors. They can differentiate into, and I'll put this right here. I'll blow up this one. This first one. This is your megakaryoblast. So mega means it's big, karyo just a cell type. Blast, anytime you see the word blast, it's a new cell, or they're going to be building cells. Blasts are builders. Okay, so a megakaryoblast, through differentiation, is going to eventually make a megakaryocyte. Okay, and eventually that's going to turn into your platelets. So this is one cell line through megakaryoblast to megakaryocyte, and makes your platelets. This is under the influence of TPO. Okay, so TPO will cause your platelets to go up. So if TPO is a hormone that comes out, if I say it goes up, it's going to influence these cell lines to make more platelets. It's going to follow the megakaryoblast, megakaryocyte platelet line. The next one it can make, it's called a pro-erythroblast. Whenever you see the word pro in front of something, it means it's the inactive form of that hormone, or that structure, that substance, that molecule. We have pro-insulin, which means it's got to be cleaved to become insulin. So a pro-hormone eventually will become cleaved to make the actual active hormone. So these pro-erythroblasts eventually will become your erythrocytes. Okay, so pro-erythroblast, erythrocyte, and that's your red blood cell. This is under the influence of the hormone EPO. Erythropoietin, just know EPO for now. We'll do this a lot more in a little bit. So EPO is when you have low O2 tension in the blood, means we don't have enough red blood cells. We need more red blood cells to get our O2 levels back up again. Okay, so that's another cell line that these myeloid progenitor cells can turn into. The last differentiation it can do, or the third to last, is myeloblasts. Okay. And these myeloblasts will eventually turn into, here's your eosinophil. This is your basophil. And lastly is your neutrophil. So those are the three cells that are going to come from the myeloblast. Eosinophils, basophils, and neutrophils. These also have a special name, granulocytes. Because they have a bunch of granules inside. All those little dots are inside. They're called granules. They're called granulocytes. So eosinophil, basophil, neutrophils are your granulocytes because they have all the stuff inside. And they come from the myeloblast. Don't worry about what causes these things to go up or not. Okay. The last differentiation for these myeloid progenitor cells is going to be your monoblast. Monoblasts. And they, in turn, will make monocytes. If you look at that monocyte, what's missing inside of it? Granules. So these types of cells are called agranulocytes because they don't have the granules in them. So monocyte is an example of an agranulocyte. So looking at this picture, all we did is we just talked about these common myeloid progenitors, and through cell differentiation, where do they wind up? Okay. Everything that's written on here, you just have to know. Don't worry about the other proteins and hormones that relate to the other type of white blood cells. Now, the last little bit is this common lymphoid progenitor. Which cells have we not talked about yet? Lymphocytes. And these are the ones that come from here. Okay? So this makes the precursor cell is a lymphoblast. Lymphoblast, again, these are the precursor cells. The immature cells are going to eventually turn into it. And these lymphoblasts will then differentiate into a lymphocyte. And we know we have T and we have the B ones. T cells and the B cells for the lymphocyte. T lymphocyte and B lymphocyte. So now you've gone through from hematopoietic stem cells. You can go down the myeloid line and see what differentiates there, or the lymphoid line, B cells and T cells. So if you have chronic lymphoid leukemia, you're not going to have any T cells or B cells, or you'd be very deficient in the T cells and the B cells and the lymphocytes. If you have chronic myeloid leukemia, you're going to be low in red blood cells and basophils, neutrophils, monocytes, eosinophils. They're going to be low because you don't have the myeloid progenitor cells to make all these cell lines. So that is kind of how stem cell differentiation works and how we get our different cells. So erythropoiesis, that's why it's EPO, makes red blood cells. Thrombopoiesis, okay, thrombopoietin, TPO, makes platelets, and leukopoiesis makes white blood cells. So erythropoiesis, the production of red blood cells is regulated to provide adequate O2. The oxygen is the main homeostatic variable for this. When oxygen levels drop, O2 tension goes down, so we're like, hey, we need more red blood cells. So we kick in this hormone called EPO to make more red blood cells. And this is sensed by the kidneys. The kidneys secrete EPO. So if someone has kidney failure, they're not going to have enough EPO, and they're at risk later on for developing what? If you don't have anemia, because you don't have the EPO available. So a lot of these chronic renal failure patients get anemic later on because of the EPO. Red blood cells also require iron, folic acid, and B12 to be synthesized properly, which is why when you're learning about anemias, you have to know the source. Is it a B12 problem? Is it an iron problem? Is it folic acid is the problem? What is going on that you can't create normal red blood cells? And that's a lot of where this blood count comes in. What are you looking at? And so forth. So you can't just look at red blood cells by itself. If someone's anemic, iron composition, folic acid levels, B12 levels, because those are all responsible for making red blood cells. So process of stem cell differentiation, cells are going to start decreasing in size. Hemoglobin is produced. It's red in color. Okay, remember, it's made up of iron oxide, which is rust. So when iron binds to oxygen, it turns red, and that's why our blood is red. Different animals, I think octopus have copper instead of the iron in hemoglobin. That's why their blood is whatever color it is. Different animals have different metals in their blood, red blood cells, causing different animals to have different colored blood. In mammals, we use iron. Cell organelles decrease over time and eventually disappears. The nucleus goes away and disappears, and that's why red blood cells kind of don't have that nucleus anymore. Final stage are these immature red blood cells called reticulocytes. So when you get a reticulocyte count, if that number is going up and higher than normal, that means you're producing a lot of red blood cells right now because you have a lot of reticulocytes. You have a lot of immature red blood cells floating around that are starting to mature because you needed it. Normally, less than 1% of circulating red blood cells are the immature ones. So when you see that number going up, usually like sickle cell patients will have a high retic count because they're constantly churning out more red blood cells to replace the ones that were damaged. So again, if it's elevated, that means that the demand for red blood cells went up. It could be either after a hemorrhage, so if you cut yourself and you're bleeding out like crazy, you have to replace that blood because you need the oxygen carrying capacity back. So red blood cells go into overdrive for production to increase your O2 capacity. And useful index for red blood cell production. So here's an example. You go to altitude. So factors that decrease oxygenation of the blood. Low blood volume. You cut your femoral artery, blood's squirting out everywhere. Hemorrhagic, low blood volume. That's one cause of it. Anemia, lack of red blood cells. Think of red blood cells as the trucks in your blood. And on those trucks, they have milk crates. And every milk crate is a hemoglobin. And each milk crate can carry 4 bottles of milk. So if I want to carry more milk across, I got to have more milk crates, which are the hemoglobins. I got to bump those up. If I want everything to go faster, I need those trucks to go faster. So I increase my heart rate to allow the trucks to go faster, making oxygen delivery happen. So you'll see how the heart rate comes into play when it comes to that. Low hemoglobin, poor blood flow, pulmonary disease, these are all things that can cause you to have low oxygen in your blood. When this happens, tissue oxygenation goes down. Okay. Erythropoietin by the kidney starts to increase. Erythropoietin goes up, tells these hematopoietic stem cells, hey, let's start making more red blood cells. So we have the proerythroblasts, more red blood cells, therefore more oxygen carrying capacity. The O2 goes up, back to normal range, and the EPO shuts off. We went back to our normal set point. We don't need that reaction anymore. We got our O2 levels back up. We're okay. The system shuts off. That's a negative feedback. Thrombopoiesis, how you make platelets. Again, platelets also have no nucleus. Disc-shaped fragments. The rate of platelet formation is under the influence of TPO, thrombopoietin. Thrombopoietin is secreted by the liver and the kidneys, so they're both involved. Mainly the liver, so people who have liver disease, they're not going to be producing a lot of TPO, so their platelet levels go down, and they're at risk of bleeding. The concentration of TPO is related to the amount of platelets in circulation. If we have the right amount of platelets, there's no reason for TPO to come out. When the platelet levels drop, TPO comes out to bring our platelet levels back up again. High TPO result from low platelet count, thrombocytopenia. Okay, whenever you see penias, that means it's a low number. Okay, here you go. Give you a couple. Leukopoiesis, depends on the cell type. We went over this already. T lymphocytes from the thymus, B lymphocytes from the bone and the lymph. We have the granular white cells, eosinophils, neutrophils, and basophils. And the monocytes are there as well. They'll later become macrophages. That's pretty much it as far as how we create those 3 types of cells. Any questions about what stimulates and what creates the 3 different types of cells? Okay. So red blood cells are very pliable. It allows them to pass through microcirculation. So when we get cut, they can kind of squeeze their way through the capillaries to get into the area that was injured. That's why we bleed. That's why you get red in some areas, because the blood gets into the area. The red blood cells get there and cause it to be red. They can withstand large osmotic pressures when they pass through the renal medullary circulation. Why is that important? Where do you want the red blood cells to stay? In the blood, or you want them to go into the urine? In the blood. You should never see blood in the urine. Why? Because it can withstand the osmotic pressures. That's pushing it out. It keeps them in. And when they leave the bone marrow, they have some key cytoplasmic proteins. Obviously, hemoglobin is the big one. It can carry 4 units of O2 per every hemoglobin. Okay, we have glycolytic enzymes. Okay, glycolytic, because we don't have mitochondria. There are no cell organelles in these things. There's no mitochondria to get ATP generated. So the red blood cells come packaged with its own food supply, glucose. It uses it up to get around. That's how it gets ATP via glycolysis. It just breaks up the glucose. We also have an enzyme called carbonic anhydrase, and this is very essential for carbon dioxide transport in the blood. So carbonic anhydrase is an enzyme. We're going to talk about it a lot when we get to the pulmonary system. But these are the big 3 things that are in the red blood cells: the hemoglobin, glycolytic enzymes for energy, and carbonic anhydrase, which is the enzyme allows for rapid, for this equation to occur. And we'll get to this a lot more in pulmonary. Normal lifespan of a red blood cell is about 100 to 120 days. How many months is that? 3 to 4 months. Okay? So I mentioned before, we talked about glucose and we talked about how sticky the blood can get. So when your blood gets sticky, these little glucose molecules are going to stick to the red blood cells. The more glucoses that are stuck to the red blood cells, we measure that as what? Anyone know? Our hemoglobin A1C, which is really glycated hemoglobin. Glycated because it got sugar all over it. How often do we check an A1C in a diabetic patient? Every 3 to 4 months. Why? Because the red blood cells are going to cycle through. So every 3 or 4 months, we know that your red blood cells have cycled through. The better your sugar levels are going over time, the less sugar is available to stick to the red blood cells. And in time, your A1C should go down. So you can't check A1C every week. It's not going to change. So A1C you do every 3 to 4 months. Your fasting plasma glucose you can do anytime you want because it's just checking glucose. So that's why it's important for those 120 days, because we know every about 120, 3 to 4 months, your red blood cells will circulate. About 1% is cycled daily. Aging red blood cells are removed by macrophages, mainly in the spleen. That's kind of where the spleen comes in, very important. The end product of hemoglobin breakdown is bilirubin. And this bilirubin then, through different portals and circulations, either gets brought back up into the liver and it gets mixed in with your bile in the gallbladder. And then you eat some food. Normally fatty, fried foods is what kicks in that stuff a lot. And the bile gets secreted into the intestine, then you get rid of the waste. A lot of the reason why the stool is brown is because of the bilirubin from leftover blood, breaking down and bacteria in there as well. So, just like we talked about the balance of the production versus the removal, we talked about that with like the ciliary bodies in the eye with the rate of aqueous humor production. And if that gets off, Either your pressure goes up or it goes down. The CSF, the same thing. Choroid epithelial cells create the CSF. We drain it later on, and as long as those are balanced, your CSF will be balanced. Same thing with anemia. As long as the red cell mass that's being created is equal to what's being destroyed, then you will be stable with your red blood cells. If the red cell mass is decreased, we call it anemia. If it's increased, it's called polycythemia. Okay, so polycythemia means too many cells. And that's what we're talking about there. So red blood cells can go too high. When red blood cells go too high, the viscosity of the blood increases. It becomes thicker because there's more stuff in it. Makes it thicker. Some indices that we look at for red blood cells. So when you get your CBC with your differential, some of these other things are going to start popping up in those areas. So hemoglobin concentration. We want to know how much hemoglobin is there per volume of blood. So concentration is how much hemoglobin is there. The next one is your hematocrit, or the packed cell volume. This is just the ratio of red blood cells to whole blood. You guys do the experiment with the capillary tubes, and you prick your finger and you put blood in it, and then you spin it, and you see what percentage you get. That's your hematocrit. Tells you how much cells are there compared to the entire blood volume. Because remember, when you spin the blood, all the cells come to the bottom and the plasma goes to the top. And you can figure out your hematocrit. It's just a percentage. So if you have your tube, okay, and here's your plasma all the way there. And then your red blood cells are finally here. This is 100, here's 0, that's 40, so like 40% is your hematocrit. You just look where that line is, from cells to plasma, and that tells your hematocrit. Okay, the ratio of red cells, because these are all going to be red cells down at the bottom, to the whole blood. The last thing is your red blood cell count. So how many red blood cells are there in 1 liter of blood? The more red blood cells, that shows that you have the oxygen carrying capacity because you have the red blood cells there. If that number goes down, you're losing red blood cells, you're going to lose your oxygen carrying capacity, therefore you get winded and stuff like that faster. So this is just looking at the number of red blood cells. Now we want to look at the size. How big are they? And that is what we look at with the mean cell volume. So the average volume of a single red cell is expressed in femtoliters. All you have to know for this is if you are less than 80 femtoliters, that's considered a small red blood cell, giving you what's called a microcytic, small cell size. Microcytic anemia is dealing with only talking about the size of the red blood cell. If they're greater than 100 femtoliters, they're considered large, and that is macrocytic anemia. The cells are big now. So that's what we look at with average size of the red blood cell. How big are they? Are they the appropriate size? Because if they're not made the right way, they won't be able to have the right binding capacity, and you'll have anemia. So here's another one, talking about iron. Read this one on your own. Okay, other indices of red blood cells. The adequacy of how our hemoglobin is made. It has to be made properly. If it's not made properly, it's not going to have the right space. I give you the example of the milk carton, the milk crate. Milk crate should fit 4 gallons of milk in it perfectly. If the crate is misshapen, you won't be able to fit the 4 bottles in there anymore. You may only be able to fit 2 or 3. Therefore, your oxygen carrying capacity goes down because you don't have the right hemoglobin there. So we look at the average amount of hemoglobin in a red blood cell. How much is there? That's mean cell hemoglobin. How much hemoglobin is in each cell? I don't know a right number, but we want to look. What is the right, do we have the right value? And that is just your hemoglobin out of your red blood cells. So if we know our hemoglobin is 5,000, our red blood cells are 100, you divide them out, and that tells you how many hemoglobins there are for each red blood cell. Everyone good? Remember, the red blood cell is the truck. On that truck, it's going to store hundreds of milk carton crates. Each crate is a hemoglobin. They all got to fit in that truck. So how many crates can it hold? That tells you this mean cell hemoglobin. The other last one is just the average concentration of hemoglobin in the red blood cell is looking at more of a global hemoglobin there. Blood smears, you have to look at with a microscope to see the actual size and shape of these things. And you will see the reticulocyte counts here because you'll see the immature red blood cells on a peripheral smear. We don't do these individually. We all just order it and the lab takes care of it for us. But at least you understand when you get a CBC now, what all the little indices mean and what actually are you looking at. We want to make sure that the red blood cells are properly constructed, make sure the hemoglobin's there, and so that we can have our O2 capacity. Any questions so far about red blood cells? Now let's talk about antigens and antibodies. So red blood cells have on them called antigens, also called an agglutinogen, and they're found on the surface of these red blood cells, and they allow our body to recognize self from non-self. Okay? We also have floating in your body in some cell types. We have antibodies called agglutinins, and they're secreted by lymphocytes in response to foreign cells in the plasma. So we have an ABO system, which are the antigens that are on the surface of the red blood cells. If you are type A blood, you have a surface A antigen on your red blood cell. If you are type B blood, you have the B antigen on the red blood cell. If you are type AB, you have both A and B antigens on the surface of the red blood cell. And if you're type O, you don't have any, neither the A or the B, on these antigens on the red blood cell. You don't have any. These just tell you what type you have. So if you're A, you have the A antigen on your red blood cells. Okay, everyone good with this part right now? Okay. Plasma contains antibodies against the antigens not present on the red blood cell. This is how you protect against bad transfusion reactions. You have to match the red blood cell type to prevent this from happening. If you have type A blood, you have anti-B antibodies floating around in your bloodstream. Your red blood cell is A. It has the A antigens. You don't want B antigens in your bloodstream. So you have the antibodies to B. And if you get B blood, these antibodies are going to attack and combine with those red blood cells, and they get clumped. It's called an agglutinin reaction, or transfusion reaction. They get clumpy, and they don't circulate very well. If you have type B blood, you have the anti-A antibodies. So A and B are just the opposite. Really easy. If you're type AB, you have no antibodies in your blood because you already have the A and the B antigen on the red blood cell. So you don't want any antibody because then you'll be attacking yourself constantly. So that's why type AB is the universal recipient. They can get any blood because they don't have any antibodies in their bloodstream. Nothing for A, nothing for B. You can give them A, you can give them B, AB, O. Doesn't matter. They can take it all because they don't have the antibodies floating around. Now let's look at type O. They have anti-A and anti-B floating around in their bloodstream. But the red blood cell has no antigens on it. That's why they're the universal donor. They can give all their red blood cells to anyone because the red blood cells that they create have no antigens on them. So yeah, I could be AB and have type A and B antibodies floating around, but I'm getting blood that doesn't have any antigens on it anyway. There's nothing to react to. Everyone good on that? Make sense? Just make sure you understand antibodies and antigens. Yes?
So only gets blood from
Pretty much. So transfusion reaction, that receives the wrong blood type, antibodies will bind to the erythrocytes, call an agglutination, and potentially hemolysis, where the red blood cells just burst and they just are destroyed. Yes?
So what causes like the B positive?
Well, that's the next one. We're going there right now. So that's just AB. We haven't gotten to the rhesus factor yet, the RH factor plus minus, which we're doing right now. So here's the RH factor, also known as antigen D. Blow it up. So Rh positive people have the antigen on their red blood cells for D. Rh negative does not have the antigen, and they will not have any antibodies unless they are exposed to an Rh positive blood, either through blood transfusion or pregnancy. When you are pregnant, we don't know the blood type of the baby. We know the mother's blood type. If the mother is Rh negative, she's never been exposed to the D antigen at all, therefore has no antibodies. This is what I'm talking about here, issues in pregnancy. If an Rh negative mother, during delivery, we don't know when this could happen, okay? Blood can mix between the mother and the infant, or the baby, whatever. Okay? If the fetal blood, the baby's blood, did have the positive antigen, now the mother's blood has been exposed to it. And the mother is going to start making antibodies to the D antigen because it's not normal for them to have Rh positive because they're always negative. So, we're not worried about the pregnancy now. We're worried about future pregnancies. Because if she gets pregnant a second time, and that baby has Rh positive blood, she now has the antibodies for Rh positive. So what do you think the mother's antibodies are going to do to that fetus? It's going to attack it and kill it. It's going to see that is a foreign body. So what we do, we give an Rh negative mother a medicine called RhoGAM during that pregnancy. And what RhoGAM does is it's going to inactivate all the anti-D antibodies that may be produced if there is a mixture of blood. We're not saving the pregnancy now because the baby's already developed and you're okay. It's the next one that you're worried about. So you give RhoGAM so that Rh negative mother will not have any antibodies to D floating around in her system that, God forbid, could be activated on her next pregnancy, causing an unwanted miscarriage. Yes?
When would you, so you'd give the RhoGAM while they're pregnant, they're currently?
While they're in delivery.
Okay, gotcha.
You do it during delivery. First baby. And usually every other one for a negative. You want to make sure that every time they...
At the beginning or every time you give birth?
Every time you give birth. That's when the mixture of blood could happen, is that delivery. No other time.
You can kill the baby after that.
Not in the new infant. It's the next one you're worried about. So you want to inactivate anything that could be made for the second baby.
So it's treated first pregnancy?
You treat the first one because you don't know. If the mother is Rh positive already, you don't need to worry about this. It doesn't matter. It's only when they're negative you want to prevent the second and third, fourth pregnancies.
So
Yes?
if the mom is pregnant, negative, her first baby is positive. So
Doesn't matter. You give it anyway. You don't know the baby's blood type.
Oh, okay.
You don't know. You can't. Regardless. You don't know. Any Rh negative mother in a pregnancy and delivery, you have to give RhoGAM.
Thank you.
You give that.
That's for the men.
Yes. Okay, so basically here we go. Okay, first pregnancy, we have an Rh positive baby. Here's the placenta. We could get some mixing of the blood, causing the mother in between pregnancies to have this anti-Rh antibodies. So that when she gets pregnant the second time, if that fetus is Rh positive, it's going to have the D antigen on its red blood cells. You don't want that. Remember, the antibodies go from the mother to the fetus. That's our passive immunity. So the antibodies you have to the D is already there. It's going to attack the fetus very, very early on. You won't be able to get pregnant. That's why we give RhoGAM to inactivate all those anti-Rh antibodies that could be there. We don't know, but we know if you have Rh negative mother, give RhoGAM every pregnancy to inactivate those anti-Ds. Any questions so far? Now we're moving on to clotting factors, and then we'll be done. So clotting has two different parts. There's a platelet part, and there is a clotting part. Clotting is slow process. Platelets are fast. Okay? So one of the great properties of our blood is the ability that we can clot. So if you cut yourself, you can stop bleeding. And it's an interaction between our blood vessel walls, circulating platelets, and clotting proteins in the plasma, all coming together to cause what's to be called hemostasis, stopping the flow of blood. Now, the other important thing, once we make the clot, we can't have the clot be there forever. We have to get rid of it. It's done its job. The clot is like scaffolding. If you ever see people are making buildings, they put the scaffolding around the entire building so you can get up to the higher floors. But once you're done with the building, the scaffolding comes away. You don't leave it there forever. So when we have a clot due to an injury, eventually that clot, once the area is healed, the clot has to go away. So one of the other properties is we have to break down the clot, and that's called fibrinolysis. Fibrin is part of the structures of the clot. Lysis means to break up, to destroy. We're breaking up the clot. That's fibrinolysis. It's a very fine balance between activation of these mechanisms to prevent bleeding and excessive activation, which can cause a lot of clots in the body. So when we're talking about coagulation, it's basically like a seesaw. You have things that will induce clotting and things that hinder clotting. Okay? If you're in this balance where you're inducing clotting, that means you are hypercoagulable. I think that's the way I said it. Coagulable. I don't know. We'll figure it out. It's been a long day. So hypercoagulable state. You're going to be clotting easier. Okay? And then the other way is your anticoagulation. Okay? We don't want you to clot. So it's a fine balance, depending on what hormonal influences are involved. Your liver function will tip you in the scales of certain things. Certain people have certain genetic factors, factor V Leiden, Christmas disease, all these different things you'll learn about with hematology that lead to either excessive bleeding or excessive clots. Okay, so that's what we're looking at here. Are we clotting too easily or are we clotting too much? Or too easy, too thick, hard. Here's a platelet party because that's what basically the platelets do. They all hang out together, get sticky, and they cause you to clot. So, overview of hemostasis. The first thing that happens is vasoconstriction. Okay? What's the first thing you do if you cut your arm? You apply pressure. Okay? That is a real thing to do to help with vasoconstriction. You're applying pressure to the area to help stop bleeding. So when this happens, we get platelet activation and clot formation, release of serotonin, thromboxane A2, which are vasoconstrictors. And our clotting protein thrombin is here as well. So thrombin, thrombus, those are making clots. So kind of get that in your head, what's going on. Platelet plug formation occurs at the site of damage. This is your primary hemostasis. This is the first thing that happens. All the platelets come in the area and they get the platelet party, get all sticky together, and they try and plug that hole that you're having this problem in. Later on, we get a clot formation, which is a fibrin mesh, has platelets, other trapped cells in there, and that's called your secondary hemostasis. Okay, so the first thing we're going to talk about, we'll go through each one of these in detail. So clinical correlation, obviously increased tissue pressure is effective to prevent bleeding. Tourniquets, clamps, those things will stop bleeding as well. What it does, increases pressure, reduces blood vessel radius, decreases local blood flow. So when that happens, you prevent washout of your procoagulant factors. We want all the healing factors to stay in the area that's damaged. By applying pressure, you keep those procoagulant factors all in that area. If you don't, blood flow is going to keep going and it'll wash all those things away. You want all these procoagulant factors to stay in the area to get the best effect. So primary hemostasis, this is a positive feedback loop. Okay, this is the first positive feedback loop that we're actually going through. All the other ones were negative feedback loops. This is a positive one. The first phase that happens is platelet adhesion. They all have A's. So as we go through each three of them, they're going to say platelet adhesion, aggregation, activation. So I didn't make this up, guys, but that's the way they classify it. So first one, platelet adhesion. Different platelet receptors. We have the integrin family is here. Von Willebrand factor is here. And here's your thromboxane A2 and thrombin. These are the 3 or 4 receptors on the platelets that get activated to cause adhesion. So the platelets start to stick together. The next step, platelet activation. Now we got to activate them. Get them ready to go. The factors that are released, ADP is one of them. Serotonin, and here's your thromboxane A2 again. Von Willebrand factors here. Here's your calcium. Fibrinogen, factor 5. Okay. Anyone here phlebotomy? Which one is the two? Isn't there a calcium citrate, one of them? What is it? What's the purpose of that one? The calcium does what? Yeah. Keeps it from clotting. So you're giving them the calcium to inactivate the calcium, essentially, right? That's something in there to inactivate the calcium to prevent clotting so that your blood will stay liquid for longer. If you don't have that additive in there, it's going to start clotting. Blood, if you leave blood alone, it's going to clot on its own. There are chemicals inside those tubes to prevent certain things from happening. You deactivate it. One of them is deactivating the calcium. And then platelet-derived growth factor is there as well. So these 4 things I circled are the main ones I want you to know as far as what's responsible for activating these platelets. The last one is finally our platelet aggregation. This forms the entire platelet plug. This is the third and final step. Yes?
How would we view the phases within the intrinsic and extrinsic?
We'll get there in a little bit.
Oh, okay.
We're getting there. That is all clotting.
Okay.
This is just platelets plug. Okay. So that deals with clotting. Wait there in a second. So platelet plug is prevented from extending beyond the site of injury by prostacyclin and nitric oxide. So if we have a damage to our vessel wall, okay, blood is just leaking out like crazy through it, the platelet plug will go into this area only. Oops. Okay, that's the platelet plug. It doesn't extend over to the side because that's healthy vessel. They aren't secreting the cytokines that will cause all the platelets to get activated. So because of the intact endothelial cells and the nitric oxide inhibit platelet activation. So nitric oxide's there, nitric oxide's on that side, prostacyclins are on those sides, and they help with vasodilation on opposite ends of the injury. And that's how the platelet plug only stays in that one area. It doesn't extend. So these are only talking about platelets only. Platelet activation is a fast process. So platelets, is this really, yeah, okay, so here we are. Antiplatelet drugs are used to prevent thrombosis. Aspirin and NSAIDs, okay, don't we give baby aspirin to people to prevent cardiac problems? Why? What are we giving the aspirin for? When you say thin the blood now, what do you actually mean by that? You prevent platelets from clotting. That's all aspirin, Plavix, those drugs, NSAIDs, they're mainly with platelets. Platelets is what causes occlusion in your coronary vessels that cause heart attacks. So by giving aspirin, we make the platelets less sticky. So if you do have a problem in one of your coronary vessels, platelets are going to go in there normally because that's what they're supposed to do. You have a crack in your vessel, you have an injury. Platelets are going to go in there and seal up the wound. But if you deal with a coronary vessel that's small already as it is, you get this clump of vessels of these platelets, you may occlude a good portion of that coronary vessel, and now you cause a heart attack. So by giving aspirin, you prevent those platelets from getting sticky to prevent a clot from forming in the coronary vessel that will cause a heart attack. So NSAIDs and aspirin inhibit thromboxane A2, clopidogrel, which is your Plavix, they attack the ADP. And again, this is not, you don't have to know this for your exam, just reinforcing what we talked about. Kind of like, here's your ADP, there's your ADP, that's what it's doing. So Plavix blocks that from happening. So therefore, you don't get this platelet activation response. Therefore, no clotting. Yes?
With von Willebrand's disease, you bleed a lot when you get hurt, right?
I think so.
So how does that work?
Because you don't have the clotting factors or the platelets won't get activated. Because you need the von Willebrand factor to activate the platelets, and now you're losing it, so you can't do certain things with platelet activation, and that's why you bleed. Okay. So that was just on platelets. So whenever you're treating an arterial problem, think about platelets. Platelets are the problem with the arteries. Clotting is a venous problem. What's a DVT? Deep vein thrombosis. It's a clot in the veins. Why? Veins are slow moving. The blood doesn't go very fast in veins. It goes very fast in arteries. So platelets have the time to do things in the arteries. You don't have the time for those clotting factors to do anything. The one time you will get a clot on an arterial side is with atrial fibrillation. Because with atrial fibrillation, in the left atrium, you have a little thing there called the left atrial appendage. It's just a little outcropping off the left atrium, and it's there when you need really, really high cardiac output. That little appendage can pop out, and your left atrium side got bigger. The problem is it doesn't pop out very much, and it just sits there. And with atrial fibrillation, blood can start to pool in that area. It doesn't get out because of the way the atria squeeze. There you can get clots because the blood will sit there and pool for a long period of time, and then it breaks free. So clotting, think about veins, platelets, arteries, they all work together. But when you're thinking about it later on, aspirin, Plavix are for arterial problems, coronary artery disease. Coumadin, Lovenox, heparin are to prevent clots in your legs, the venous side. Okay? So the blood clot occurs when fibrinogen is converted to fibrin. There is a whole cascade. I'm not going to make you memorize the entire cascade. We're going to pick up certain parts that are important. Clots can occur without platelet activation, but again, there's usually a parallel of the primary hemostasis, which is the arterial, the clotting of the platelets, and the secondary hemostasis, which is clotting, using all the clotting factors. Clotting can be initiated by either one of two pathways, the intrinsic or the extrinsic pathway. Either one will result in clotting. Each pathway is a cascade of reactions which turn the inactive protein into the active form. So fibrinogen is the inactive form which needs to go to fibrin, which is the active form. This is a safety mechanism. We can have fibrinogen floating around in our blood all the time, but it's not active. It's not going to clot us. If it was fibrin floating around in our system all the time, fibrin is the active one at will clot. So by having these inactive proteins floating around, our body is ready to go. In case there is an injury, we're ready to go with our clotting factors. All we have to do is activate them, but they're there. So they're floating around. Again, they're not normally activated in blood because clotting factors are in low concentration, only need to be risen or elevated when there is a need for it. So the intrinsic pathway is when blood contacts a negatively charged surface, will trigger the intrinsic pathway. Okay, so the intrinsic pathway, it just says exposure to collagen, which is then going to set this whole cascade to happen. You don't need to memorize all these numbers. Okay? Just understand the main thing is this common pathway here. And if you look, the red is the extrinsic, the blue is the intrinsic. They both wind up right there at this activation of factor X. And their goal, through their cascade of protein activations, the goal is to get factor X converted into its active form. Okay? This is stimulated via the intrinsic pathway. The extrinsic pathway, calcium is here as well, to activate factor X. Okay? I emphasize X a lot, and I say that because when these drug companies make up these drug names, they're not very creative. Well, they are creative, but they make it very easy. Lovenox, Xarelto, Fundaparinox. What are some of the other ones that are out? These anticoagulation drugs. Anyway, they all have X in it because they activate the factor X. That's where they're going towards. Lovenox, Fundaparinox, I forgot what else there is. They all have X in it because that's where they're targeting is this factor X. You knock out this, you knock out the intrinsic pathway and the extrinsic pathway. They both converge at factor X. And if you're giving drugs that inhibit factor X, are you going to be able to clot? No. And that's the purpose of these anticoagulation drugs. Warfarin, Coumadin, Lovenox, they don't want you to clot. Okay? So by inhibiting this is the common pathway from the intrinsic and the extrinsic. They both come here. So the intrinsic, negatively charged surface. The extrinsic pathway is the blood contact cells outside the vascular endothelium. So that's going to activate the extrinsic factor or tissue factor. It's sensing tissue. But again, they all wind up in this common pathway. So the goal, from here on out, you got to know. It's not that much, but it's a cascade again. We've now activated factor X. And it's this activated factor X that's going to turn prothrombin, the inactive form, to thrombin. That's the first step. Now, we've created thrombin. The next step thrombin is going to do, it's going to activate the fibrinogen, which is the inactive form, to the fibrin. So fibrin is now the structure that's going to start making the clot. It's the scaffolding. It's got all these little branches, and it just collects platelets and other cells that fly by. They all get stuck inside. And now you have a stable cross-linked fibrin clot. And that's clot formation. The last thing about clot formation, we talked about it in the very, very beginning. What also is a great property that we have about clots? They have to be what? Broken down and reabsorbed. The way that it's done that is with a molecule called plasminogen. And plasminogen is deposited inside every single blood clot. So the thing that's going to make it dissolve is already inside the clot, waiting to be activated. And we call it plasminogen. Anyone has ever heard of plasminogen before in something? What? What? What about from a medical perspective? Anyone see it used in as a scribe? Okay, someone comes in with a massive stroke. What is the medicine that we can give them? TPA. Tissue plasminogen activator. We're activating plasminogen. Why? We need to break up your clots. You have a massive stroke caused by a clot. We have to break it. So we give them artificial plasminogen, tissue plasminogen activator, to activate the system to break down the clot faster. And that's why we give that medicine for stroke patients. So the plasminogen is already absorbed into the fibrin clot. And I'll show you that'll be at the end. We'll get there in a second. So that's going to be dumped in there already. Clotting indices. How effective are you at clotting and stopping bleeding? There's a couple of things that we look at. The first one, bleeding time. That's a test of platelet function. We put a little nick on your arm and we time how long does it take for you to stop bleeding. Because we know what is the result of primary hemostasis. What cells are responsible for primary hemostasis? Platelets. So bleeding time is looking at platelet function. How when do you stop that primary stopping of bleeding? So you record time to stop, and obviously aspirin is going to increase bleeding time. Okay, phlebotomists. Okay, you ever get the people who keep constantly bleeding, they can't stop? You ever ask them what their medical history is? They could probably either on aspirin, or they have liver disease, or they just can't produce the proteins to stop them bleeding. So they'll continue to bleed like crazy. The next one, the prothrombin time, PT, or also the INR, the International Normalized Ratio. Basically, they're the same thing. They look at the extrinsic coagulation pathway. So remember we said the intrinsic pathway, the extrinsic pathway, they both go to that common pathway where we can knock it out, but each one has their own method as well. So we look at prothrombin time, evaluates our extrinsic coagulation pathway. So if you are taking Coumadin, warfarin, those affect the intrinsic pathway, and that's why the PT-INR is going to be altered for those medications. The PTT, partial thromboplastin time, looks at the intrinsic pathway. Okay, the intrinsic pathway looks at heparin. Okay, so heparin and Lovenox are two different types of medicines. Well, not really low enough, but Coumadin anyway. Okay, so PT, intrinsic pathway, PT-INR, warfarin, Coumadin. The intrinsic pathway, partial thromboplastin-time, PTT, heparin are the main ones for that one. So if your patient's on heparin, the INR are not going to tell you anything because heparin's affecting the extrinsic pathway. So we have to look at the PTT. So if you ever order a coagulation panel, you're going to get PT-INR and the PTT so you know the intrinsic and extrinsic pathways, what they're doing. So clinical correlation, you don't have to know all this, but remember, I bring it up is because all those factors are produced in the liver. So if you have liver failure, you're not going to be producing a lot of these clotting proteins, so therefore bleeding time goes up. This is an example. Vitamin K rich foods, they alter the metabolism of these clotting proteins. That's why I have to be very careful with vitamin K rich foods. If someone is on Coumadin or warfarin, these foods can give you a false elevated INR or alter your INR so it's hard to get into range. You don't have to know this for anything else. Just some of you may have seen this before. Now you're putting pieces together. So that's all why I give that. Anticoagulants. Capillary endothelium is a major source of these anticoagulant factors. We have this tissue factor pathway inhibitor that blocks the activated extrinsic pathway. Antithrombin 3 binds to activated factor X. Heparin augments this antithrombin 3. Thrombomodulin just binds to thrombin. And here's your protein CNS. They help together. You don't have to just know that these are the other factors that are involved with clotting. Antithrombin 3, thrombomodulin, protein CNS. These are just extra anticoagulants. So now the clot is done. It served its purpose. The endothelium has been replaced. So now the clot can be dissolved and it's ready to go. So this plasminogen is already in the clot waiting to be activated. It's cleaved to produce plasmin, just like anything with the ogens are the inactive form, fibrinogen, plasminogen. We have to activate it to the plasmin or the fibrin. And once you break down this plasmin, it breaks down the fibrin and the fibrinogen in there to small little parts, and it just dissolves away and it gets washed out. Breakdown products are scavenged by macrophages, and fibrinolysis, soon after that clot is formed, it starts breaking it down. There are two things to activate your plasminogen to convert it to plasmin. Here's your tissue plasminogen activator, the TPA. And we have this urokinase type, another one, plasminogen activator. It's in the name. You're activating plasminogen. We know that when you do that, it converts it to plasmin, which is going to break up the clot. Plasmin is not active in circulation because if it was active in circulation, it would break down all the clots. So by having it made in a way that it only gets activated after the clot is formed, it kind of helps protect us so that we don't break up all the clots that we need to help stop bleeding. And any free plasma is very bound to a protein real fast to kind of inactivate it. Whenever a hormone or a chemical molecule is bound to a protein, it's usually inactivated because it's stuck to a protein. It's not free. It's not doing anything. It's stuck to a protein. So this is kind of what happens. Here's your entire clot. There's your plasminogen. It's kind of waiting around. And then once one of these two factors kicks in, it'll activate plasmin, which will then start breaking up the clot. And you start getting these fibrin breakdown products. And you can look at those things. Any questions about how we break up a clot? Okay. So warfarin, an interesting story about warfarin. Anyone know anything about warfarin? It's really Coumadin, which is from coumarin, which was rat poison. And what they found out was in Wisconsin, they had a field of these clovers, and these cows were eating the clovers, and the cows were bleeding out. And they figured out it was the chemical in the clover that was causing the anticoagulation to happen, which was the coumarin. First they made it as rat poison. They're like, oh, we can give it to people, and it can stop their blood from clotting if they have AFib. So it's called warfarin because it's the Wisconsin Alumni Research Foundation is the organization that discovered it and did it. So it's warfarin, but Coumadin is the brand, generic term for it. Anyway, let's take a break. Come back at 1:50, and we'll start cardio.